So it's really exciting to have my colleague Chris Rozell in the lab with me. Chris is an engineer, and as an engineer, engaging you in this project on depression has been such a gift to me and my lab. What really drew you to this experiment?
Well, I think as an engineer, we have a certain skill set of studying complex systems, of trying to take data and understand the information that's in that data so we can make useful decisions about it. And we always hope that our work is going to have impact. And so we look for opportunities and collaborations to do that. I see these situations in psychiatric disorders where there's such important problems to solve and there's so much suffering associated with them, but the assessment and the evaluation is so subjective. It just seemed like it was screaming for the sort of quantitative tools that we build as engineers and specifically as neuroengineers.
And I'd really love to hear you sort of summarize what you think the real key features are of our new paper.
Yeah. In my mind, I think there are three things that I would focus on in understanding this paper. What was it able to confirm out of a long history of work? What does it advance right now? And what sort of future does it point toward? So I think the first thing, what does it confirm? You have 20 years of history doing these sort of surgeries, and I think this paper confirmed clinically that the sort of procedure that you've been developing and your team has been developing expertise in implementing works, and it works well. In this cohort of patients that are reported in this paper, 90% of them showed clinical response, meaning that their symptoms dropped by half from what they were. 70% were in clinical remission at the end of the trial. And these are profoundly sick patients. So I think the first thing to note is that it confirms that with experience and expertise, people can get better with this therapy. Now, that remarkable response rate actually provided a really unique setting for us to do research, because the challenge is the case management for these patients is complicated, partially because it's subjective. Unlike other disorders, we can't measure directly what it is that the patient's experiencing. If they're having trouble walking, we can measure something about how long it takes them to walk. But here we only have their subjective reports. And that makes it difficult for the psychiatric teams to know, are we dealing with the moment-to-moment mood variations of real life that we all experience? Or are we dealing with disease relapse? We used new neurotechnology that allowed us to record from the brain over 6 months while the patients were receiving therapy and getting better. And then we were able to use new artificial intelligence technology that we developed in order to spot patterns in the brain of activity that changes when the patient transitions from being very, very sick to being in stable recovery. So it gives us a marker or a readout of how the patient's brain actually is. That can be given back to the clinical teams as another piece of objective information about how their recovery is going and to help them manage these complex cases more effectively and more efficiently. Using this objective measure of recovery, we were able to then go to the imaging of the patient's brain, of the anatomy and the structure, but also to the behavior of the patient's own face when they were talking to their psychiatrist. And we were able to see changes that marked how sick the patient was and how they were recovering. So I think this points to a future where we're able to take a holistic look at many different data streams and help us bring those all together to manage these complex clinical cases where neuromodulation is used to try and treat their treatment-resistant depression.
Where do you see the role of AI going in all of this?
Well, there have been amazing technical advances in artificial intelligence, and I think as a field and as a society, we're still trying to understand what the biggest impacts are going to be and also what the kind of ethical boundaries should be in how we apply them. I'll say in my own mind, I think the biggest bang for the buck in AI is in physician decision support. It's in trying to take the subjective intuition that's been built up over years in treating patients and turning it into something quantitative and objective that can help us scale therapies that are complicated, but also make better, more efficient outcomes for patients. So I'm not trying to replace a psychiatrist here. Their job is too hard for that. But I am trying to give them a stethoscope, right? Unlike every other part of medicine, when you're trying to treat a disorder or an organ in the body, you go measure something about that organ. If you have cardiovascular disease, you do a blood test and you check lipid levels. You have ways to measure what it is that you're trying to treat. And I think depression stands out in that we're trying to treat a brain disorder, as you said, but we don't have ways until now to measure the brain directly and to measure the recovery of the patient. So in some ways, I think the most powerful things we can do are use these new technologies to spot complex patterns in data that turn intuition into measurement and into objective characterization, so that we can give that as another piece of information to clinical teams as they manage these complicated clinical cases.